MAFLD which may develop MAFLD. MAFLD may develop MASH, and we finally develop any major adverse event. So major adverse event could be divided into either major adverse liver related events or major adverse cardiovascular events. We'll be discussing these as MACE and MALO in the subsequent slides. Also, the diabetes may be associated with MAFLD or may develop at any time course, and the major adverse cardiovascular events may develop before or even once the MAFLD develop. So we'll be discussing this in all the large population-based studies based on the clinical and lab parameters, by how biopsy features will finally predict the major adverse outcomes. Non-invasive test in form of FIB4, MAST or ELF score. Then we'll also be tabulating some of the population-based studies, the GWAS, and how AI and machine learning has helped as far as the risk prediction models are concerned. So in this multi-center study done in Europe, where they assess the prognostic evaluation of a risk score for long-term liver-related outcomes in the general population. So at the beginning, none of these patients had any liver disease. Of total 14,726 patients. The derivation cohort comprised of 43% of the patients and 2 validation cohorts. They assessed all the baseline parameters, clinical and other parameters, and the component which was found to have maximum importance were age, gender, fasting glucose, cholesterol, AST, ALT, GGT, and platelet count. The median follow-up of all these patients were more than 12 years, and based on this they found they had the liver risk score where minimal was less than 6 and high risk was more than equal to 15. What they found that these patients, those who had LSM of more than 10, the liver risk score, it fared significantly better as compared to the other conventional non-invasive tests like FIB4 and APRI in both the validation cohort, and this was also seen when the fibroscan was more than 15. They found that once the liver risk score it increases more than 10, the cumulative incidence of mortality or hospitalization, it progressively increases as far as the liver related hospitalization is concerned, but it plateaus somehow once the liver score is more than 10. They also found that when the high risk score, that is score of more than 15, it was compared to the minimal risk score, that is less than 6. They found that it correlated well with the liver related mortality, liver related hospitalization, as well as development of liver cancers over a period of more than 12 to 20 years. So they found that the novel risk scores which predict the degree of liver stiffness and future liver related outcomes in an adult general population without a known liver disease. Then what all major adverse liver related outcomes we have to see. So this was very well answered by this long-term major adverse liver outcomes in 1,260 patients of non-cirrhotic NAFLD. These had NAFLD at baseline. It was a Swedish cohort. The NAFLD was diagnosed based on biopsy or ultrasound. So, fibroscan was done in some set of patients. The baseline FIB4 was 0.97, BMI of 29, and LSM was at the starting was 6.4. And the major outcomes were development of cirrhosis, development of esophageal varices, decompensation, HRS, ascites, bleeding, HCC, or a liver transplant or liver-related death. They found that compared to the non-MAFLD patients, the incidence of MALO was significantly higher as compared to the reference or the general population. And the cumulative incidence at 20 years was nearly 35% if they had baseline F3 fibrosis compared to those who had F0 or F1 where the cumulative incidence was not more than 3%. They've also found that the FIB4, if it is intermediate risk, they has or high risk at baseline, these non-invasive tests also fared equally well as compared to the fibrosis, and they found that the prognostic capacity of non-invasive test is similar to liver biopsy when prediction for liver-related events are concerned. Then another important factor that we need to consider, which is answered by this Splendor study, which is the surgical procedure and long-term effectiveness in the MASH disease for obesity risk, where the cumulative incidence of MALO and MACE was assessed. all these patients were biopsy proven NASH with F1 to F3 fibrosis, total 1158 patients, and they were grouped into bariatric surgery or non-surgical care with a BMI of 44. And the primary outcome was incidence of mallow or MACE. What they found at in the non-surgical cohort compared to the bariatric surgery cohort, that means the non-surgical cohort are those who were just on standard medical treatment. The incidence of mallow and MACE were significantly higher, with mallow seen in up to 9.6% incidence at 10 years, and MACE was seen in up to 15.7%. So they said that the NASH with obesity, they definitely have higher incidence of major adverse outcome. So whether one-time FIB4 measurement is sufficient or repeated measures are required, or how they help in prediction of major liver-related outcomes. Again, this Swedish population who were enrolled between 1985 to 96, repeat FIB4 was done within 2.9 years or up to 5 years, and median follow-up of 16 years. The median FIB4 at baseline was 0.9, and only 1.5% of the total population had a high FIB4, that is more than 2.67. So this is the overall change of FIB4 and how it impacts or the total hazard ratio with the 1 point increase in the FIB4 on repeated measures. So based on the repeated measures, they had 9 set of patients, that is the low which remains low, or high which remains high, and subsequently high which improves, or low goes to intermediate. And the cumulative incidence of mallow based on the category of FIB4, that is once they become from low to high, the incidence was 7.9 times higher, with the time to event development of major liver related event of 7.9. Even those who had baseline intermediate moving to high FIB4 score within 5 years, they also had a higher incidence of mallow within 9 years. And those who have high and they remain high, they were nearly having 17 times higher incidence of mallow compared to the reference population. Then another non-invasive test is the ELF score, which predicts the liver-related outcomes in general population. This was the Finnish study of 6,000 patients. The ELF score was done one time only, with less than 7.7 as rule out and more than 11.3 for cirrhosis. The mean ELF score was 8.8, and what they found that as the increase of the ELF score at baseline, the chances of development of liver-related events are higher. And when they stratified ELF score based on less than 9.8 or more than 11.3, they found that compared to the ELF of less than 9.8, both 9.8 to 11.3 as well as more than 11.3 had significantly higher chances of development of liver-related outcomes within 5 years. Then few more non-invasive tests, especially this MAST score. This MAST score was initially assessed for the at-risk NASH patients. At-risk NASH are those who have the NASH score of more than 4 or fibrosis of more than equal to 2. And the original study, it found that MAST score significantly predicts rule in or rule out the at-risk NASH. In this retrospective analysis of 346 patients with median follow-up of up to 29 months, what they found, and based on the previous study, they have categorized based the MAST score range of less than 0.16, which rules out, and more than 0.24, which rules in. And they found that MAST score of more than 0.2 to 1, it clearly, the cumulative event is significantly higher as compared to the MAST score, which is within 0 to 0.65. So so MAFLD itself is a spectrum and it has 3 subtypes. So do MAFLD itself is homogeneous as far as the risk for development of future liver-related events are concerned, or there is any difference? Which was answered by this nutrition health assessment and examination survey data of around 12,000 patients, where hepatic liver fat was seen in up to 4,500 patients, median follow-up of 23 years. Among these patients, diabetes was seen in 846 patients, obese or overweight in 2,600, and lean was seen in 406. And what they found that all-cause mortality was higher compared to the reference population in those MAFLD who have diabetes or those who have lean but with metabolic disorder. And the obese MAFLD, they had no difference as far as the mortality is concerned compared to the reference population. So they further divided the MAFLD spectrum into the healthy MAFLD and non-healthy MAFLD. Among the overall obese of 32,000 patients, the prevalence of healthy MAFLD among those who have fat in liver, it was 6.9, and unhealthy MAFLD was categorized into in up to 93%. And they found that the adverse events of MACE, that is cardiovascular event, development of significant or advanced fibrosis, it is higher in those who have unhealthy MAFLD, that is they have either cardiopulmonary metabolic risk factors or they are diabetic at baseline compared to those who don't have diabetes but they are just obese. This was also found to correlate well as when they assess the all-cause mortality, the cardiovascular risk factors as well as cancer-related mortality. And they said that the heterogeneity and spectrum of metabolic dysfunction that exist in overweight and obese has to be answered. So even whether MAFLD and NAFLD, they have different outcome. When the overall patients of 12,000 patients followed up for 22 years with fat, the fatty liver disease was either characterized based on ultrasound or CAP value of more than 285. The MAFLD by definition was defined in 89% of the patient. NAFLD by definition, that is liver fat with less than 20 grams of alcohol intake or less than 30 grams in male, was categorized in 81% of the patients. And what they found that the all-cause mortality was, when it was not adjusted, it was found that all-cause mortality was significantly higher in those who have MAFLD compared to non-MAFLD or NAFLD compared to non-NAFLD. And the major liver-related mortality influence was for MAFLD was because of alcohol usage, and for NAFLD it was because of the fibrosis, high CRP and insulin resistance. So they said that the liver-related mortality among the NAFLD is primarily driven by insulin resistance, and in MAFLD it is primarily driven by the alcohol usage. Then few population-based studies where MAFLD increases the all-cause mortality in Australia. It was a 20-year longitudinal cohort study. The outcome was either decompensation, liver cancer or liver-related death followed for nearly 19 years. And the all-cause mortality was higher in MAFLD compared to non-MAFLD. And even in those MAFLD who have one criteria, meeting one criteria, they have higher mortality at 20 years compared to no MAFLD, and it increases if the number of criteria for MAFLD, they are meeting more number of criteria. Few more study from Asian population. This study by Oguswara in Asians with MAFLD in 875 patient, median follow-up of 5.7 years, diabetes seen in 51%. Liver-related outcomes were measured and MAFLD was diagnosed based on biopsy, and they concluded that higher FIB4 at baseline, ALT and development of HCC over during the progression or during the follow-up have impact on the outcomes. This study in the Chinese population of more than 20,000 patients, median follow-up of 5 years, diabetes seen only 13%. Liver-related event was measured as outcome and ultrasound-based diagnosis for fat, and they found that diabetic MAFLD had a higher risk of development of liver-related event compared to others, and obese MAFLD had the lowest. Nabi et al. In 2022, they assessed in the same thing in the Caucasian population. Diabetes was not reported, and along with liver-related event, other cardiovascular risk factor, extrahepatic cancers and CKD, and they found that MAFLD population, they have higher morbidity and mortality. Then the cardiovascular events were also studied in the same Australian population of for follow-up of 20 years, where the 3-point MACE, that is 3-point is development of non-fatal MI, non-fatal stroke or death due to cardiovascular disease was assessed. Median follow-up 19 years. And they found that both NAFLD and MAFLD, if defined, they have good prediction as far as 3P MACE was concerned. The other clinical outcomes when assessed for MAFLD and NAFLD, they found that the cardiovascular mortality, the non-fatal cardiovascular events, CKD events and extrahepatic cancers, they were higher. The incidence of diabetes is also higher in the MAFLD group, or those not meeting, compared to those not meeting the NAFLD criteria. In this large retrospective longitudinal study, where hepatic fat was assessed based on the ultrasound finding, follow-up of up to 5 years, the overall diabetes incidence was 6.1%. None of these patients had diabetes at the onset, and they found that the red line, that is the MAFLD group, either obese or those with cardiometabolic risk factor, they had the highest chances or chances of development of new diabetes compared to other subclasses. This also brings us to the genomic association of how MAFLD in large population-based studies, how the genetic association is there. And this is important because before we move into the machine learning or AI, the large studies, so the genome-wide association of the metabolic dysfunction in a Korean population of MAFLD of around 2,282 patients and control group. MAFLD was subdivided into the metabolic dysfunction MAFLD and obese or overweight MAFLD. These were the routine jivas which have been found to have association with the NAFLD definition, that is PNPLA3, TM6, SF2, HSD, MBOD, GSK and SAM50. But for MAFLD, it was found that the PNPLA3, the particular SNP, they had a higher association compared to the non-MAFLD group. And the GATA-D, this GATA-D is a chimeric gene, associated gene, which is usually seen in the neurodegenerative disorders. They also subclassified MAFLD, and they found that the association of the PNPLA3 was significantly associated with MAFLD and MAFLD subtypes in the Korean population. So when we define the fatty liver disease based on the MAFLD diagnosis, only two genes in their population, that is GATA-D and PNPLA3, was found to have association, and other conventional genes were not found to have significance. This study, again studying the genome-wide study, revealing the genetic risk factor for hepatic fat content. This is a UK biobank study, and they assessed the fat based on MRI-PDFF as well as the fatty liver index. The FLI of more than 60 was defined to have fatty liver disease, and MRI-PDFF of more than 5. The genetic association 5 loci from the PDFF cohort, that is CREB, GCM, PNPLA3, TM6, SF2 and ApoE, were found to have susceptibility, and among the FLI cohort 49 loci were identified, and when they both were compared, it was found that the MRI-PDFF candidate loci and the FLI, they had significant genetic correlation, and this was the first study where a non-invasive marker was assessed for the presence of genomic association. So how machine learning studies have incorporated all the non-invasive test, clinical parameters as well as the genetic factors. This study from Mamta Bhatt's group, where the machine learning approach to classify cardiovascular diseases in patients with NAFLD in UK biobank cohort. Of NAFLD cohort of 400 patients, and the no cardiovascular disease was seen in 446. Duration of the sample was collected between 2006 to 10. It was a single point data collection. MRI-PDFF defined of more than 5%. And genetic analysis which was seen was nearly more than 3.5 lakhs SNPs, with top 100 were chosen. The aim was to classify the cardiovascular disease in the NAFLD patients. All the clinical lifestyle, that is how sedentary their lifestyle is, what number of hours they see TV and all, they were also assessed, and the genetic variables were assessed. In the overall cohort, 33% of these patients were diabetic, BMI of 29. And in the Shapley chart, the diabetes and triglyceride was found to have maximum contribution apart from other standard cardiovascular risk factors. So this was the this was the data set, how they approached the machine learning. 70% of the overall sample was in the training cohort and 30% for the testing cohort. And what they found that compared to the prediction for cardiovascular risk factor, the clinical prediction, clinical plus genetic or clinical, genetic and lifestyle, they have maximum or they have the best prediction as far as the cardiovascular risk factors are concerned in the MAFLD population. This another study among patients who have already underwent liver transplantation of 1400 patients who underwent transplant between 2008 to 2019. The aim was to risk prediction model for development of MACE post-LT, 30-day mortality and cardiovascular event. MACE was defined as development of any three, that is heart failure, stroke or non-fatal MI. On the Shapley analysis, the top influence of variables were right ventricular systolic pressure, age, creatinine, diabetes and left ventricular ejection fraction post-MI. And what they found that based on the XGBoost machine learning model had the best prediction as far as the development of MACE and other secondary objectives are concerned in the post-liver transplant cohort. Then this is one review article from Mamta Bhatt's group where they have applied the AI was applied for the omics data, and in fact what they have tried to show that the MAFLD plus, that is the MAFLD with MAFLD cirrhosis or MAFLD HCC or liver related deaths, the role of transcriptomes and metabolome have maximum been studied, but a recent study published in JHAP report in 2023 where they have assessed the lipidome, and the lipidomics they change right from F0 level to F3, and what they have shown that the change in the lipidomic profile is at the crucial juncture. The crucial juncture for MAFLD is development of F0, F1 or F2 and beyond is very well predicted with the lipidomics. So to summarize, the factors which are very much important when we assess the risk prediction is the MAFLD subtype. All the subtypes of MAFLD is not same. Diabetic and cardiometabolic risk factors, they in previous study have been assessed as metabolically unhealthy, and the risk for progression, all-cause mortality, MACE and all have been defined. Morbidly obese from the bariatric surgery group, where the non-surgery patients, they were found to have significant higher MALO and MACE. Fibrosis or the conventional methods of F2 and above have shown to have overall progression both in the population-based studies. FIB4 or the repeated FIB4 have been shown to have good correlation as far as the prediction for MALO is concerned, even the ELF score. Liver risk score has also shown to have good association with the prediction for MALO or overall mortality, but these liver risk scores must be defined based on our own population, because this has all these risk scores may be different in different geographical or genetics. The MAST score has shown good correlation with the MALO. Omics is something which is interesting because till now diagnosis is there, but how they help in progression and precision-based medicine would be important. Machine learning models which will integrate all the above factors for risk prediction and the genomic landscaping for MAFLD for our set of patients.